Hi, everyone. Welcome. And we are waiting to make sure we've cleared the waiting room, so we will get started shortly. Holly, if you could, why don't we stop sharing just for a minute so that we
Sure.
can say hello to each other, and then we
Yeah.
can jump back on. Thank you.
And I think you're probably all set to start.
Great. Thank you, Brian. Welcome, everyone, and thank you for joining us today. Purpose of this meeting is to have Guidehouse present formally in accordance with the Chapter 639 process, the rates for FQHCs. So I will shortly turn the meeting over to Holly McDonald for her presentation, but in brief, I am Jennifer Patterson. I am the Director of Policy for the Office of Main Care Services, and my policy team includes Kristen Merrill and Kathy Coolidge, who are joining us today. Don't know whether David Jorgensen is on, but his team, Peter or Brian, do you know whether David is on?
No, I do not believe David is on.
I just admitted him.
Oh, okay.
Oh, great. There we go.
Well, I will ask David to do the briefest introduction of his team, and then we will turn it over to Guidehouse to introduce their team and present the rates. David Jorgensen, are you on? And if you could just quickly introduce your team by name so everybody knows who's here from Main Care.
So apologies for just jumping on right now. I'm David Jorgensen, Director of Data Analytics and Rate Setting. And from the rate setting team, we have Peter Kraut, our Rate Reform Manager, Amanda Lee, our Rate Reform Coordinator, Grace Williams, Financial Analyst, Brian Lumbra, project manager on this rate reform effort, Dwayne Parsons, financial analyst. And did I miss anybody? Is Jessica on?
Jess is not on, but I would also note that we have provider relations specialist Shannon Beggs on the line.
Yes, thank you, Peter. And I just saw you, Shannon. Thank you for joining us today. Is there anyone else from Main Care that we haven't introduced? Okay, well, Holly, without further ado, I will turn the presentation over to you.
Great, thanks, Jenny. And just as a quick introduction, so my name is Holly McDonald. And we have the Guidehouse team here with us as well, which includes David Garbarino, Josh Mim, and Sean Clare. Hopefully you've heard from one of us at some point. We have been working with Main Care throughout this process. And I'm gonna go ahead and share my screen, and we're gonna walk through the rate methodology process. Okay. Well, thank you. Okay, so real quick, we're going to go over the agenda today, which is a quick introduction into this process for anybody who has not attended one of these meetings before. Then we will do a walkthrough of the alternative payment method rate methodology. We will do a rate walkthrough, and this is using dummy numbers on the and this matches the data confirmations and proposed draft rates that everybody received a couple weeks ago. And then we will have time for public comment. So, everyone, thank you for attending, and let's go ahead and jump in. So for the introduction, again, this will be an overview, and many of you have already seen this, but because this is the public comment meeting, we wanted to kind of level set on what has been happening throughout this process. So this process has been a joint effort between Main Care, the FQHCs, and Guidehouse as we work towards making an updated payment methodology alternative payment method. So there are two main intents of this process. The first was to work with the FQHCs to obtain those necessary costs and visits in order to calculate a new FQHC rebased T1015 rate. And that new rate is based on the total cost and total visits, and we'll get more depth into that as we go along. The next part of this process was to obtain data at a level of granularity, which would allow the state to submit an updated state plan amendment. And this was at the directive of CMS. There was some ambiguity in the past on which services and costs should be included and billed under the T1015. And so this process really allowed the state to get more clarity on what services were being billed, what services were being offered to different FQHCs, and building those costs into the rate or allowing them to be reimbursed outside the T101 rate, which we'll be talking about. Before we move on to the rate methodology, does anybody have any questions about the process itself and what we've gone through? Okay, let's keep moving on. So the next piece is an overview of the rate methodology. So this process was kicked off by the Maine Care Public Law 2021, Chapter 47, which directed Maine Care to create an alternative payment method. And this is allowed under the BIPA legislation, the federal legislation, which requires FQHCs to be reimbursed under a prospective payment system. And there's very clear regulations and rules on there of how the PPS is calculated, but they do allow an alternative payment method. And so that is where the state decided to go ahead and create an updated base rate based on the reasonable costs incurred in the FQH fiscal years ending in 2018 and 2019. And then on top of this, we would add the approved changes in scope in the FQHC's market basket inflation. So one of the things that goes along with an alternative payment method is that all APMs that are calculated for an FQHC must be equal to or greater than the PPS reimbursement rate. And this is an important requirement that CMS goes forward. So going forward, the PPS will be calculated as well as you also have the option of the APM. The other piece under BIPA is that FQHCs always have the option of reimbursement under the PPS or the APM. So FQHCs don't have to choose to be reimbursed under the APM. You do have the choice of the PPS. So with the APM, you have the encounter rate that's been calculated. And here you'll see there are, as part of this process, as we talked about, the clarification was needed on what costs would be reimbursed under that T101 and what costs would be paid for outside of the T101. And so here you'll see some of those services that are being reimbursed fee for service according to otherwise approved sections of the Maine Care state plan. And these include services that are already being reimbursed outside of fee for service. Some of them include interpreter services, IUDs, and then there also are a couple changes. For example, the going forward, services for and associated with dental crowns and dentures will be paid fee for service according to the requirements within Section 25 under dental services. And so these are some of the changes that came about through conversations with Maine Care and the association and the FQHCs about what would be helpful to be billed outside, as well as what would work better inside or outside the T115. The next clarification that we want to provide is that some services are not reimbursable to an FQHC under that T115, and that these services must be provided and billed through other applicable sections of the Maine Care Benefits Manual. The services here are not inclusive, so they're not limited to just these services, but here are some examples. And these services include DME, laboratory, radiology, and ambulance services.
Holly, hi, this is Christina. I have a quick question on the previous slide.
Sure.
So here, right, should we be adding that the APM, I would say that the encounters would receive APM on services in scope, and then you refer to the main state plan. Here, it looks like we'll be reversed for all of the approved section of the Maine Medicaid state plan and would be reimbursed our APM, but they first have to be in scope with HRSA, correct? These are in scope services that are subject to the APM.
Yeah, so HRSA is a different, so we want to, their Maine Care is separating things from HRSA. So HRSA has their own requirements. And the APM is those items that are reimbursable under the state plan. So under federal regulation, the T1015 has to cover Medicare covered services, and main care state plan services. And so under that main care Medicaid state plan, these are some of the services that will be paid fee for service outside of it that are also covered under the state plan. Does that clarify?
No. So what you're saying that moving forward, we do not have to have a service in scope with HRSA in order to receive our APM rate?
That is
Would you
like
correct,
me to-
Christina.
Would you like me to jump in, Holly?
Yes, Kristen, please.
Yes.
Hi, Christina. It was great question. Thanks for asking it. So we, through discussions with CMS and through HRSA, we did determine that the two are not mutually exclusive. And so in an effort to simplify this for both us and obviously the FQHCs, we've elected to disconnect the two from each other. So the determination on what is included within the encounter or what is separate from the encounter is strictly based on, main care's determination. It is not in any way, shape, or form related to your HRSA.
So in doing so, does that mean that all the qualifying providers listed in the main state plan would also be qualified to receive APM payment if they're listed as qualified providers for those services?
If they are listed as qualified providers for those services, so the requirements for Medicaid agencies related to the encounter is that there are certain services performed by certain providers that are required to be in there, and then any services outside of those are at our discretion. And so primarily the list of providers that were previously in scope, those stay the same. There are some additions though, obviously with the expansion of the other services that we have assessed that are currently approved in the state plan.
And the new updated policy will specify exactly when a qualifying provider within one of the chapters of the state plan. I think because that's been an area of confusion, but I mean, that's really good news.
Yeah, we think so too. I think the way we're anticipating the policy working is probably listing those providers or services rather that would not be included, to similar to how we framed it on the slide, because essentially the list of what is reimbursed separately is smaller than what is now going to be considered within the encounter. So it's easier to say what's not in.
Thank you. That's a big deal. Thank you.
Thank you.
Thank you, Kristen. Any other questions about this? Okay, moving forward. Okay, so we're moving on to the APM rate methodology, looking at the actual calculation. And here I'm going to turn it over to Josh. And Josh, I'll keep the slides up.
Thanks, Holly. So what we want to do is just kind of walk through, where we took the costs up, where we got the costs, and the visits, and just detail what was taken out. And the next, in the slides in the letter, we'll do more of that, but this just is kind of a general overview of, the costs and visits that were in and out. So for costs, we use cost reports, 224 cost reports ending in 2018 or 2019. And for this, we used the costs or expenses from column 7. So that would be after adjustments. So with that, we took we took row 100 for the total costs, and that's not in here. And then for the exclusions, we had to take away services that were either reimbursed via fee for service or that had other reimbursement sources, similar like Ryan White, 340B stuff. And then for non-FQHC services like DME and lab. And again, that should have been all detailed out, and we'll show you that on the dummy letter. And then further, so past that, we use the supplemental cost report to impute cost for services that were not broken out in the 224. And we can go more into that, but essentially we took the charges from the supplemental cost report, imputed to cost, and then took that out of the total cost number of the 224. And then for visits, the total eligible visits were essentially the total visits reported on the supplemental cost report with exclusions for services associated with the exclusions and cost from both the 224 and the supplemental. So once we had those two numbers, we calculated a per visit rate, which was just the adjusted costs over the adjusted visits. And then once we had that number, we inflated it and applied the changes in scope. And that was done sequentially so that, you know, it would have essentially mimic how the rate would have gone throughout the year. So inflate and then change the scope if applicable, inflate, etc. So the per visit rate times the inflation gives us the 2023 per visit rate. Okay, any questions on that before we move on to more details? Okay, all right, go ahead, Holly, we can switch the. All right, so this next session is just a walkthrough of essentially the letter or the document that was set out that details the cost. And really the goal here is to not only detail out the process, but allow you as a provider to match everything up. So we try to show you to the best of our ability what we pulled from the 224, what we pulled from the supplemental cost report, the calculations we made, so that essentially you can come up with the rate that we came up with and see where all the numbers came from. So this first section here is costs, and this was, you know, definitely I would say the largest section, had the most moving pieces. So in here we start on line 1 with the total cost, line 100, column 7. And then we go into the exclusions, and you can see the exclusions detailed out here. Under the reference column, we see what line on the cost report that came from, and we give the amounts for both 2018 and 2019, and then the total. And then line 11 just has corrections. If there were 224 corrections that were needed, and there were very few, they would be detailed out here. And then line 12 gives us essentially the total cost that we take away from the 224. And then the next section starts trying to remove, removing costs from that total using the supplemental cost report. So we get the total charges from the supplemental cost report, use the total costs above to get a cost to charge ratio. And then we apply that to certain services. So we take the total charges for the services, you know, lines 15 through 19, and apply the CCR to get a cost for those, and then exclude that from line 12. So that gives us our total, or I should say our final cost with both 224 and SCR exclusions on line 22. Okay, go ahead and flip it, Holly. Okay, actually, can you go back? I did forget one. Sure. And Holly, you probably were thinking that. So lines 6 and 9 so lines 69 and 79 are other. And this provider here, this dummy provider, does have exclusions that come from there. And these are very varied. There can be a number of things that are put under here. And so in parentheses, you see breakout page, and we'll detail what those are. But essentially, we went through that with the provider to categorize those as either included or excluded. If you as a provider didn't have anything in these lines, then you did not get that page that details these out. So even though you may have had entries on line 69 or 79, if there were no exclusions, we didn't detail out what were on those lines. Okay, I'm sorry, now you can turn it on. Okay, so starting at the top, again, we detailed out the costs here. So starting from line 22, and now we go into the visits. So for this, again, we just took the total visits from the SCR. This details out any exclusions. And for the exclusions, we just summed the units for these particular services. You know, the diabetes group education, tobacco cessation, particularly just group. We did not do the individual for tobacco cessation. Can't say that. And then labs, standalone encounters. And those, again, were very few providers had a standalone lab. And that gives us our total visits excluded, and then the total visits with adjustments on line 28.
I have a quick question. It's Christina again.
Yep.
So my question is, if you're going to exclude the costs, say for crowns and dentures, why wouldn't you also exclude the visits associated with that?
That was a comment that came in, and we're definitely taking that back and reviewing it. I know the state is talking about it and can comment if they want, but that's one of the things that we're looking at.
Right, because it will inflate, it decreases the cost of those services, but the visits remain the same. And so that's just a little, the methodology or the logic. I guess I'm just a little confused. It seems if you exclude costs for those services, the corresponding visits to those services would also be excluded.
Yep, and that makes sense. And like I said, we're taking it back and we'll provide more information on the decision that we come up with. I don't know that the state's going to address that here. I don't want to speak for them. But like I said, I know that came in. I know they're looking at that.
Yes, I think just Christina, to answer your question, I mean, absolutely. We have received that comment. We welcome that comment, and we would be happy to have folks articulate that formally, but it's not necessary. So we definitely, this is one of the things that we'll be considering and addressing in the response to comments.
And is this something that you want each individual FQHC when they resubmit, or, you know, they've received their proposed, they're going to go back, look at
I
their-
would say, I mean, I don't think each individual FQHC needs to raise
Okay,
the
perfect.
question. It's something that we're considering it to be a comment on the methodology as a whole.
All right, excellent. Thank you.
And-
Can I ask a question on another comment? I'm sorry, from the prior page. How about trending 2018? Because if the trending doesn't start until 2019, you're going to miss the inflation of 1 year to bring that cost current to the base that you start to trend.
Yeah, Kurt, and you know, we saw that comment come in, and that's another one that we're taking back and looking at. So I know no decision's been made yet. Again, not speaking for the state, but yeah, that's something that we will address as well.
Okay, thank you.
And I did see a comment come across the chat, just popped up about tobacco cessation, not taking the visits out for the individual therapy. We only took the group out, and thank you for that. And again, that's one of the things that we're looking at, and we'll provide either an explanation, or if we decide to do something different, we'll let you know. And as far as that goes, if there are changes to the method that come out of the comments and we need further data or we need refinement, we will reach out again to you. There's nothing that you need to submit just now in case that does happen. If that does happen, we'll reach out if we need anything.
And specifically to that smoking and tobacco cessation question. So here you'll see these are the state plan services that we covered that will be reimbursed fee for service. And currently the proposed rate methodology is that only the group will be reimbursed separately, and the individual will be a part of that APM encounter rate. And so just a clarification between the individual versus the group for that smoking and tobacco cessation counseling.
So you're saying there won't be a separate reimbursement for services that are under tab 4, right? So in addition to the PPS rate, we get separate reimbursement for G008, G009, smoking cessation counseling, et cetera. That will no longer be, and it will be included in.
For individual right now, so group, so group counseling, it's still a separate fee for service, but the individual in counseling, those costs were built into the encounter rate.
And Holly, my comment, I'm sorry, it was me that put that in, this is Sharon, was just simply about making sure that those were not counted on the template that they completed for Guidehouse as a visit, right? Because they're not typically done as an independent visit. It's part of a regular office visit. So it's just making sure that the visit count is not being inflated by pieces of another visit, essentially.
Right, so tab 4 could very well be duplicative of the visits. If somebody put a total on those visits, could be duplicative. They really will be. I don't know anyone, honestly, that does smoking cessation as the only thing performed that day. And so maybe some health centers weren't aware of that, right?
Right, and that's one of the reasons that we used, you know, we reached out to you and said, you know, we want to make sure that we have total unique visits to start with, which should just be the top boxes on everything. And then as we delved down into units, we took a look at, okay, would this be considered an actual visit or did it go along with things? So, but I hear that concern. Yes, thank you. Okay, and I think we were on the second page. Yes, okay. All right, so we started, I think we got down to the visits, and then the next section details out the inflation and if any scope changes were applicable. And And it shows here the formula that we used to come up with the inflation percentage. And then line 36 details out the initial per visit rate calculation, and then 37 is with the inflation and scope change applied. And again, just to reiterate Kurt's comment, we did have the comment about the 2018 inflating the 2018 cost, so we will address that down the road. Okay, go on to the next page. So this page is the page that not every provider had if they did not have exclusions from either line 79 or 69. But if you did, this is just an example of what you would see. Essentially, we brought in the description from the 224 and noted whether it was included or excluded, broke it down by years and totals with the total included and total excluded. So this section really is just to make it easier for you to tie this back to your 224 and to show that everything on these lines were accounted for. And we did receive a few comments on this as well, just so I can make sure that that we did see a couple comments on the included, excluded on some of these, and we will be taking that and addressing that as well. So, okay, that's the end of the letter. Any questions about the functionality of the letter? Like I said, I know we have comments on that are still pending responses, and we're definitely working on that. Okay, back to you, Holly.
Great, thanks, Josh. So as a reminder, we wanted to just remind all the FQHCs that the deadline for the data confirmation is tomorrow, close of business. And so for that, please let us know in writing at the email here if you have any questions or comments about your reported data. And this is really, this is not related to the rate methodology. This is related to the data that's been reported. So if you think that your visit number is off or that a number got transposed, please let us know. This is your opportunity to say, hey, I think the number should be this, and here's where it comes from. And the state wanted to make sure that everybody had this opportunity to review that baseline data that goes into your rate and, make sure that everything lines up. So please take the advantage of that opportunity. And all non-responses will be taken as confirmation that the data is accurate if we do not hear from your FQHC by the end of tomorrow. And then just a quick also reminder that any comments that we received as part of the data confirmation process that were emailed to Sean at this email that pertain to the rate methodology have been recorded, but will be considered as part of the public comment process. So you won't be getting a response from Sean about that as they are rate methodology. We will confirm that we've received them, but we won't be addressing them because they'll be addressed as part of the rate methodology. And that's really to allow everybody the opportunity to participate in the public comment process. As part of this process, nobody wanted to make any decisions based on public comment before everybody had the opportunity to participate in that process. Any questions about the data confirmation?
Yeah, this is Donna Williams. I've had met with Josh and we did make some changes based on the original. Will I be getting an updated letter to be able to confirm the numbers on that piece versus the original?
Yes, so, and that's a good point, Donna. So for those that did have data errors, or not errors, I don't want to say errors. For those that had data discrepancies, that we did confirm that there was changes to be made, and we're kind of separating that from comments. So if there was a data issue and we confirmed that there was a data issue, you will definitely be getting a new letter that addresses that. And then to Holly's point, if there were comments about the methodology or, discrepancies on the numbers of how the number is calculated, those will be handled by the comment portion. Does that make sense? Okay, thanks, Donna.
Wonderful. So if there aren't any other questions about the, how the numbers were calculated, those pieces, data confirmations, we can actually move into the official public comment period. And for this, we will open it up for anybody who has any questions about or feedback on the rate methodology itself. And we will also provide the reminder here that please provide any questions or comments about the rate methodology in writing as well. It's not a requirement, but it's really helpful to the state to make sure that they have captured your full comment if you provide it in writing as well. And the public comment process will be open until April 13th, close of business.
Holly, this is Darcy. I'm not sure if this is exactly pertinent to this opening, but I wanted to just reiterate the issues that have been brought up around the visits relative to dental, and then the trending to 2018. And obviously the PCA will be submitting comments. My question though is really around something that hasn't yet been addressed, and that is the process for claims in this interim period. I don't yet have an answer. And I think since you have all the FQHCs on the call, if there is a decision or leaning toward a decision, it would be good to have a discussion about that.
So Darcy, this is Jenny. We do not have a timeline that we can share at this point. I did get your email about the claims adjustment issue, and we have confirmed with our claims adjustment unit that it's relatively straightforward to make those adjustments, but we do not have an overall time frame yet.
Okay.
But I think relatively straightforward on our end. So I think it's something that could be done relatively expeditiously without centers having to do their own adjustments.
Jenny, this is Sharon. Just one question on that, because I know this is a concern for multiple health centers, in that the typical process for sort of the voiding and reprocessing is that voids are done in one cycle and the reprocessing not until the next cycle, which can cause, you know, when we're talking about a month or two of claims being taken back, would cause potentially a cash flow issue for health centers. Is there, I know I've been gone from main care for a while, is that process changed? Or is it still sort of, you know, one piece done in one cycle and then another afterwards? And also wondering about the limit on the number of claims that can be voided at one time. Just, I don't want to see it be that health centers don't end up with payment for multiple cycles, because they won't be able to withstand, some won't be able to withstand that. You know,
No,
financially.
thank you, Sharon, for the question. I don't have that level of detail. I think what I hear is that it's relatively straightforward, but we didn't ask the question. I'm not aware of about the cycles. So we'll definitely take that into consideration and communicate further when we do get to that point.
The other thing I wonder in terms of claims reprocessing is for those dental claims that would have to go back, right, and be removed from the T1015 and processed under a code from section 25. I assume that would not be something that main care could easily process in that automated way, because they would have to then decide which code, right, to assign to a claim. So would health centers likely need to make sure they reprocess those themselves?
Good question. My guess is that you are correct. I don't know for sure though, but I will take note of that question so that we don't overlook it.
Any other questions about the rate methodology? Comments, feedback?
Hi, this is Christina. I'm just going to go back to the CCR because it's such an issue for me. I mean, I think it's fortunate that with the health centers that I'm working with, the exclusions, which is multiplied by the CCR, they've been fairly low. But I'm still having a hard time understanding why the CCR was involved. And the reason why I say that is because correct code capture is a struggle for many health centers. And oftentimes what happens is that when they know they're not going to get paid separately for something, or when they know that, say, it's not a covered service, the adjustment tends to come right off at charge entry and it's excluded from the claim. And so we were asked not just about what we would charge, but what goes on McLean, what services are billed under the T1015 or the G code. So I'm not sure if that CCR weighed heavily on some other health centers. Fortunately, the ones that I work with, it's minimal, but I just did understanding of why the CCR was included in this process.
Okay. And that's something we can work with as far as, you know, the approach and the reasoning for that. And just, I will comment that it, you know, that was a number of, or we've heard that from a number of providers about, you know, the charge master and things like that. So you're definitely not alone on that.
Hi,
Yeah.
it's, oops.
Oh, go ahead.
Hi, it's Kurt Degenfelder again. Just one question on the Ryan White. Why is that carved out? That's not something I typically see in other states as a cost that's carved out. I'm just curious to the rationale.
Yeah, so Ryan White was carved out because it has an alternative reimbursement mechanism as a federally funded program, so to avoid duplication of payment.
All right, there's a lot of other federal grants we get though that weren't carved out. Not that I'm encouraging you to do so, but just wondering why that one's different.
We also have a lot of state programs that fund that as well.
Yeah, so Kurt, you know, it was one of the ones that was identified as to avoid duplication of payment along there. So, you know, there are HRSA grants or all sorts of things, but it is a service area, or it's reimbursement fund associated with the service area. So as part of it, as we went through the other cost in the 224, it was just one of the ones that was identified as being excluded. And we can provide more information as part of the public comment.
Okay, great. Thank you.
One more question. It's Christina, sorry. I'm super excited about the dentures and the crowns, but have we discussed oral surgery that's happening, you know, in a hospital setting? Is that something that's going to be carved out fee for service?
And can you I'm sorry, can you expand?
Right.
Can you expand on that a little bit?
So for an example, pediatric dentistry, oftentimes, you know, in office, the reason why so many FQHCs have to refer out is because anesthesia in the office, oftentimes they're not equipped to do that. And so, you know, a few years back, we were like, okay, if we can get room at the hospital, then with the wait list being so long for these kids that are in pain, that need anesthesia, we could use space at the hospital and provide that service. Because it was provided at the hospital and that place of service is different, based on where, you know, the regulatory guidelines with HRSA, and I know that you're separate now, you know, essentially FQHCs could never be reimbursed a PPS rate for services that were performed even in an outpatient hospital setting. And so for our, you know, dental surgeons that may want to do this, is that something we're going to talk about being carved out? Because I know that that's a deciding factor if FQHCs are even going to offer that service, because going to the hospital and doing that and receiving, you know, an APM is just not feasible. So I was just curious as to how you just pick dentures and crowns. I feel like, you know, services provided at the hospital should also be included in that.
Christina, I'm just, so two points. The reason that we came to dentures and crowns was a result of a memo that was sent to us by MPCA specific to dentals and crowns. And we thought that the memo made a compelling argument. This is the first anyone's bringing up this question. I'm curious, when that occurs, does the hospital send a claim? So how does the hospital, I mean, I'm sure they're not doing this for free.
Yeah, what we can do, Peter, is that we can follow up with a memo. Again, these were services that were provided at a health center and then chose not to continue doing that because it wasn't feasible, right? And so what we can do is provide a memo to you with that specific service, what would be done, why the hospital setting is best, and what that means. And then you can kind of make your decision based on that. Does that sound good, fair?
Yeah, and I would just urge you to send it as a comment.
Yeah, okay, so send it as a comment, okay.
Yeah.
It looks like there was a question from Darcy in the chat about documentation from CMS on the severance of HRSA from PPS. So I don't know if you know that offhand.
So when it comes to CMS official guidance, there's, as I'm sure some of you are aware, there's limited guidance in the regulation or from CMS directly, but there isn't a tie between CMS and HRSA, and the state has been working with CMS on the state plan amendment going forward. And so the decision was made to make them two separate policies.
This is David, just to further, sort of add to that. I mean, HRSA and CMS were never connected, right? I mean, there was no severance, so there's no severing. They were never connected. HRSA has their role in FQHCs when it comes to grants. CMS has their role when it comes to setting specific reimbursement policies, specifically around BIPA. So they were sort of blended, I think, inadvertently, but they were never the same. They were never related.
Yes.
And Darcy, we could look through, I mean, we were certainly told this in conversations with CMS. And we'll look to see if we ever had anything, in writing. But yeah, they were very clear with us that they're never attached to one another in the first place. So it's not really a severance as much as just they're clarifying to us that they were never.
Exactly.
Okay, thanks, Peter.
Sure. I guess one more thing, just to answer the question Christina had brought up, I don't know, 7-8 minutes ago, just about why the CCR. And we talked about this at great length on some of the earlier calls, because a lot of FQHCs has questions on it. And the answer is that we had to have some mechanism to impute the costs of any services that were being moved out of the T1015. Because if you're moving it out of the T1015 and saying that it's billable separately, we would move the visits out of the denominator, and we had to have some way to come up with the cost to move out of the numerator. And because FQHCs, don't do cost accounting at that level, we all realize that CCRs are imperfect, but it was sort of the best methodology available. And we did know that it was going to be a very small universe of services that would be moved out, like you mentioned. And so, yeah, it really, there was no other methodology available to impute those costs. So that's the reason.
And we did have a chat come through. If the FQHCs or organizations that are attending the meeting would like to put their name and organization in the chat, it'd be great to get in attendance. Thank you. And I see them starting to come through. Thank you, everyone. So I know we're, as we kind of, we'll go back to, let's see. Again, just a reminder about the data confirmations and the deadline of tomorrow. If everyone should have received them, so please let us know if you do have any questions about the data, or anything to look at. Again, these are questions not related to the rate methodology. So if the question comes in and is considered as part of the rate methodology, we'll just add it into the public comment process. But the two deadlines we have here are tomorrow for the data confirmation and then April 13th for the public comment.
And we probably should stay on just for another couple of minutes, even if it's in silence, just giving everybody the chance to type their info into the chat.
Yes. It looks like those are continuing to come through. Thank you, everyone.
Oh, and we made it to Z. Oh, I was thinking it was everybody was doing it in alphabetical order. Just kidding.
Quick count tells me that should be mostly everybody.
Okay, perfect. Thank you, Brian.
Yeah, no problem.
Okay, well, it looks like we have 9 minutes left. We're happy to hang out here and accept any more public comments. Again, we encourage everybody to also submit those in writing to Brian at the email on your screen.
And thank you everyone for joining and for your participation in this process. We really appreciate it and are excited to be at this point.
Well, I do think we need to leave it up for the rest of the public comment process, but I think if at this point, if there are no other questions, people are welcome to depart if they so wish. We'll hang out here in case there's anybody else who adds last minute.
Jenny, I have a question for you. This is not a comment, but since we're here and nobody else has any questions, is it possible when you talk to Melina or whatever team would do the reprocessing to ask if there would be a way for for people to choose what option they would like, or is it gonna have to be all one way or the other? Because I know that quite a few of our health centers expressed that they would prefer to reprocess their own changes. So I'm just wondering, if they'll have an option or if it's gonna be all one way or the other.
Yep, I'll definitely ask that question, Sharon. And I think that was why we weren't sure. I mean, I was out on vacation, so I may have missed some of the conversation. So, but I think, I did see the email from Darcy, and clearly it did seem like a lot of centers were expressing a desire to do that themselves. We just weren't sure if they were aware that it is relatively straightforward in the ordinary instance. I mean, I think you have pointed out some examples that might be better done manually by the centers, but we want to make it as simple as possible. But absolutely, we can ask the question of whether there can be individual preference rather than the same approach for all.
Yeah, I think that many have experienced a change where there was a system-wide approach to correcting them, and there was a long time from the payment getting voided to them getting repaid for it, which just created some financial strain.
Yeah,
so
and
they
that
were-
was, I mean, when I first read that email with the way that the vote went, it looked like that might have been the concern. So that was why we wanted to see how long it would take. But I have not asked the question about the cycles, and I don't know how much that would play into it either.
Yeah. I mean, when I was there was a limit to the number of claims that could be processed during one, especially the voiding part. And so sometimes it did take multiple cycles to complete all the voids before they could even start the repayment. And that, of course, the voids would negate any payment for new services. So it would mean they wouldn't be getting a payment for quite some time. So
Yes, we want it to be as straightforward and clear as possible, and to work as well as possible. So we'll definitely.
and
have
when they
further
do it
conversation.
themselves, they can do the void and the repayment all in the same cycle. So it's just one of the advantages to doing it themselves. It's just a lot of work, right? It takes a lot of time.
Yeah, like optimally, we would have all of the instructions laid out before anybody starts with the process.
Thank you.
Jenny, I've got a question too. Again, not really a comment, but wondering whether I don't think we've been able to actually look at the state plan amendment as submitted by Maine Care. We've seen the notice that was posted, but not the SPA itself. Is that available for us to review?
Kristen, do you have an answer to that question? I don't believe it's available at this point, but
It's not yet. We have not submitted it to CMS yet.
So are you aiming to do that this week, or is the
Yes. Yep,
Okay.
submission will be submitted by end of day tomorrow. Generally speaking, we don't really share the drafts just because CMS could change, expect things to change throughout the review process. So usually once it's approved is when it goes public.
I recognize that's when it shows up on the CMS website, but if we could just have a look at what you're submitting to them with the understanding that it obviously isn't effective until it's approved, I think it would just be helpful for us to kind of think through where there's room for these comments to affect the rates based on what you have submitted to CMS.
Yeah, we can take that back internally and see. I mean, I will say in terms of these comments in particular affecting the rates, I think that might be more or less what has been part of the calculation and not so much the methodology that's going to go into the plan. But it's definitely something we can take back and discuss.
I mean, maybe I can ask a more specific question, Kristen, which is what's on my mind in asking to look at the
Okay.
document.
Okay.
There was an exchange of comments on one particular dental issue today that reminded me of some other questions that have come up with regard to dental codes. And one of the questions we had was whether there was an opportunity to adjust exactly which dental codes are outside the T1015, or whether the SPA that you're submitting is so prescriptive that we wouldn't be able to do that.
Okay, great question. The amendment that we're submitting is not going to contain specific codes. It'll contain the general service categories similar to what was outlined in our methodology notice. If not identical to what is in our methodology notice, it might change slightly, but no, we will not submit a specified list of codes. So there is opportunity through this process and through the comments that we receive to alter that if it's appropriate.
So I guess one thing I would quickly suggest is that with regard to I think the notice says dentures and crowns with regard to what's outside. If that can be stated in a more general way, or should be in your judgment, to leave room for that conversation to continue with regard to other dental procedures, I think that would be very helpful.
So the language submitted on the notice, it indicates services for and related to dentures and crowns. So it does leave a little bit of opportunity for some things. I think the other items discussed today, like the surgical services and things like that are separate. Those are distinct, like the oral surgery topic. But I think are you feeling like the broader definition of services for and associated to dentures and crowns meets what you're concerned about, or are you feeling that's not broad enough?
I'm feeling not sufficiently conversant with the details to be sure one way or the other, and just thinking in terms of not having it doing what we can to not foreclose that conversation, so that if and to the extent that those particular health centers that are deeply into those dental procedures feel strongly that those should be outside and main care agrees, that we wouldn't be sort of frozen out until the next time we can do a SPA.
I think we'd have to get
I think, Kristen, this is Sharon. There were questions around some other sort of advanced dental services and whether or not those should be pulled out as well. And some of them were really things that only one of our health centers does, but for them it's a very costly service and not really reflective in their current APM. So I think that they specifically may have submitted a comment about that.
Okay.
And then of course Christina brought up the possibility of the surgeries that require anesthesia, and I know that has come up before as well, in terms of working with folks that have developmental disabilities, that very often when they need dental procedures, they need to be put under anesthesia to get them done, because of the stress that it causes them. And so a lot of health centers and other practices, right, find it difficult to provide services for that group, because they need an environment where they can be under anesthesia and have sort of a nurse anesthetist there, or somebody, right, that can monitor how well they're doing. And so it's just those kinds of things. And I also wonder, and probably should have asked earlier, is HRSA also doesn't allow the allowance for FQHC to provide services it's not allowed in an institutional setting, right? Which is why the hospitals are not allowed hospital services. But I'm wondering too about nursing homes, because that also excludes nursing homes as an institution. And I know for some of our more rural communities, right, that the ability to get in doctors or nurses can can be made easier, right? If they can use staff from an FQHC, but in the past, we've always said, you know, we can't do that because we're not allowed to. But I'm wondering now if under main care, since that you've clearly identified that they don't have to be connected, if that would be something that would be allowable for them to bill a place of service as a nursing home.
So it won't be under the HRSA, but FQHCs will still have to be within the requirements of their federal regulation CMSs when it comes to an FQHC. So there are, I believe, place of location requirements for an FQHC when it comes to just CMS requirements.
Okay. Sorry, that comment or that question took us over the time.
Yeah. And that might be something to add into the comment about the oral surgery is if under, you know, how that would fit into the regulation of the place of requirement and how the FQHCs were doing that in a hospital setting, because you do have that limitation.
Yeah. Well, I know, I'm pretty sure that one of the things that has prevented FQHCs from doing anything in those alternative places of service is that their insurance coverage, right, goes away if they're in that environment. And so most of them don't want to have to worry about that coverage, so.
Wonderful. So it is 1:05. Are there, you know, and we can stay on if there's any further comments, but we have come to the end of the official open period for the hearing or the 6:39 meeting. Are there any other questions or comments before we end? No? Okay, well, thank you everyone so much for your participation and all your great comments and questions. We really appreciate all your involvement in this process. And, you know, please provide all those questions and comments in writing. Again, I know I keep stressing this, but it's just very helpful to have all of the thoughts that people have gone through in writing to consider. So thank you everyone so much. Have a good rest of your day.
Thank you.